The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. This is your host, Paul Wirkus, here this month talking to Josh Bonkowsky, legendary neurologist at the Primary Children's Hospital. Welcome back, Josh.
Hi, Paul. Good to be here today.
Good. Would you like to repeat your disclosures?
Yes, my disclosures are that I write content for UpToDate. I've done consulting work with Ionis and then have clinical trials with Ionis as well.
So your disclosures are that you try to educate people, advance the frontiers of science and advance frontiers of science.
Yeah, exactly.
Okay. We're all proud of you. Those are good disclosures. Thank you very much. Part of that is that it's been almost 5 years since we talked, and it's always good to talk. Welcome back. But part of it, too, is that you've just published a book in April 2026, Dancing Eyes, Dancing Feet. You want to describe again a little bit what it's about?
Yeah, this book, Dancing Eyes, Dancing Feet, took about 10 years to write. It started as kind of a series of self-reflections about my own journey in pediatric neurology, but then I realized that it also was stories about the families and children I've taken care of, and then also a realization of how much we've really seen a transformation in pediatric neurology from a specialty that was really challenging, which is still true today, but now one with lots of hope for diagnosis and treatment.
You have an interesting framing device in the book. You start off talking to one of your fellow medical students who is asking you why in the world you would want to be a pediatric neurologist. And then by the end, you come back to that. And basically the answer is, this is why I'm a pediatric neurologist.
Yes, at the time, she had said it's a terrible specialty. You see terrible diseases and make the diagnosis and then tell the family, well, see you later, good luck. And now I believe that we not only have this really new power for diagnosis that we didn't have 5 years ago, but the treatments we have are truly working well and in some cases curative. And it's just a whole different way we're thinking about what we do in our day-to-day work.
And truly at the absolute cutting edge of what's happening in medicine.
Yeah, I think one way we think about it is that the annual meeting of the Child Neurology Society, once a year meeting of a bunch of nerds in pediatric neurology, used to be a pretty backwater kind of a Elks type event. You know, you'd be like in some Best Western in the basement. And now, because of the transformation, there's so much excitement from family groups, from pharma companies about what's possible, that the meetings are kind of these more flashy venues, I should say, and with higher powered talks and science happening at the meeting.
I mentioned last week, too, that one of the things that I really appreciated about your book was the humanism and the sympathy. I think that it's very clear that you recognize that you're not just treating diseases, you're treating patients, you're treating families, you're treating situations. And I found that very moving.
Oh, thanks, Paul. It's kind of you to say. I think something I've reflected upon, which I didn't mention in the book, is that I'm in medicine, I'm in pediatric neurology, but my father is a Presbyterian minister. My grandfather was a Presbyterian minister. So I feel like I've continued in this line of working with people just in a different avenue than my father and grandfather done. But I feel that what we do is a mission in some ways to try and take care of children and their families and try and make them better.
One of the themes over the course of the book is that you have found yourself to be an accidental Utahn in the process. And in a lot of ways, it's a little bit of maybe love letter is overstating it, but to Primary Children's Hospital and to the people who have made the place where you work a great place to treat children.
Yeah, I think I totally agree with you, Paul. My wife and I matched here from medical school in California, and people were somewhat shocked. They were like, Utah? And we thought we'll be here for 3 years and on to someplace else in our careers. And instead, we've been here for over a quarter century. And the people of Utah, the people of the West. I've just loved living here, and I love the way that people think about Primary Children's Hospital. It's such a, when you say, where you work, I think people really respect that. And I appreciate that both because it makes me feel proud to be working there. And I think it also makes me feel proud that people have an institution that they trust to take care of their children.
Yeah, and it's interesting where a lot of hospitals these days are named for people who have, maybe donated a lot of money or something. A hospital that's named for a church children's organization is really kind of sweet.
Yeah, it's nice. I think that, of course, I think people from outside of Utah can have kind of mixed feelings about the way, history has happened in Utah with the influence of the LDS Church, the Mormon Church. But in fact, I think the church has set up the Primary Children's to be independent, but it's kept that name, and then now it's working as its own organization. And I think it still captures that element of history, reflects its history, but continues to move forward.
Right. That an organization said we need to do something for the kids. My background before medicine was German language and literature because that makes a lot of sense. And quoting the Erlkönig poem by Goethe, and just what a beautiful expression that is. So both, read the poem and listen to the song that you describe that's based on the poem. This feeling, this desperate feeling of a father, with a child in danger is really quite moving.
Yeah, that was something. So in the book, we do have this leader or song from those. The poem was written by a German philosopher and poet named Goethe, and then there's a great. It was set to music in a really powerful way by a composer, Franz Josef Schubert. And the children that we see in the hospital, the diseases that they have, we as physicians think, oh gosh, this is terrible. This is very hard. But then capturing what the family's feeling with the terror, the difficulty of trying to get their child well, I think this song really captures it. If you haven't had a chance to listen to it, you can hear it on YouTube or probably Spotify, I think,
Yeah, it's beautiful.
and it really captures it.
Yeah, it's beautiful. We want to talk a little bit about the diagnostic revolution in pediatric neurology. And it's interesting because one of the things that you describe in the book is when you're examining a patient and your mentor friend for you who is either just retiring or just retired.
Because he's trying not to retire. I'll just
Yeah.
speak for
Well,
on his
good.
behalf.
Good.
Yeah.
Yeah, he is a treasure. But that as he takes you back to a basic neurologic exam, and you find that by doing the exam, you were able to make the diagnosis and the power of a physical exam, which has really been something neurologists have relied on for generations. And then you describe the evolution of being able to image the nervous system from very crude imaging through more and more specialized radiologic ways to look with CT and MRI. And then now there's been a huge revolution that now we are able to look genetically at what's going on. Tell us about that.
Yeah, you've brought up a lot of points there. In pediatric neurology, we've been fortunate that when we see a patient, we can use a neurologic exam to help us pinpoint or look for aspects of the symptoms that can tell us where or how the brain is affected and maybe what disease is going on. And that is a unique aspect of neurology or pediatric neurology that's not as common in other specialties. However, starting in the 2000s, so just as kind of in residency, the hospitals around the country started to use MRI machines. And this was really the first high resolution ability to look at the brain. And so we realized as we started doing MRIs that we were often wrong in our clinical diagnoses. And so sometimes we were right, but the use of MRI changed the ability to see disease. So we could see disease much better in the brain, in the spinal cord. And we could also make diagnoses sometimes from MRI that we had never been able to make before. And so that was happening in the early 2000s. I can remember very clearly, like going down to radiology and pulling up films back in the days when films pre-computer were how people looked at images, and the old guard physicians in the radiology suite, like Dr. Nixon in his cowboy boots. So it was like a whole team down there kind of living the same experience of transitioning from ultrasounds and CAT scans to this new technology that no one really understood, but was really excited to use it. And so MRI is now is like a really standard thing, but I think people take it for granted now. But that was a big transition to suddenly be able to kind of look into the brain, see injury or disease, and have a reasonable chance to be like, okay, we think we know what we're dealing with here and what our next steps. And so that is a big change back in the early 2000s.
And simultaneously with that, then in the early 2000s, the genome was mapped, which you describe as being, like landing people on the moon. Great achievement, but how does that apply to me?
Yeah, the genome mapping and now the use of genome testing has been a surprise to me. So I followed the announcements back in 2003 when the first human genome was mapped. And at that time, it was a single person. It cost, billions of dollars. And you're like, okay, great. But it just there's no relationship to anything happening in the clinic or the hospital or ability to test patients. And then about 5 years ago, genome testing suddenly became available in clinical medicine in a realistic way. So the costs used to be quite high, but about 5 years ago, the cost got down below $10,000, which is still a sizable chunk of money. But I mean, to be realistic, $10,000 is like maybe 2 days in the ICU. So it's not really that much in the grand scheme of medicine. And now the genome costs even less. And so suddenly we could test kids in the hospital with genome testing. Those results could come back in a matter of a week. And suddenly you realize, oh my gosh, we know what the diagnosis is, and there, in some cases, there's an actual treatment. And then what's happened is that from 5 years ago today, you're like on an accelerating speedway. Like now the cost, now you can get an answer back in 2 or 3 days. The test is less than $3,000. The test is not only available like in the ICU setting, but you can do it in patients in clinic. And we no longer are kind of flying blind in the night saying, we have seizures, but we don't know why. We're like, we have seizures, we know why, and here's the medicine you should probably take that has the best chance of working. And it's for everybody. Every child has this opportunity to have a diagnosis. Every family can know what disease they're battling. It's just such a difference.
I think in your book, you mentioned that about 40% of diseases you can find a cause in genome sequencing. Did I misread that?
No, that's accurate. And there's lots of caveats and asterisks and stuff to this statement that I'm going to make. And so I'm sure listeners will call in and complain. But if you have a condition where a child is not doing well for some reason and there's not some other explanation where we think, okay, this seems like a genetic cause, we have about a 40 or 50% chance of finding the answer with a genome test. And of course, that begs the question, why can't we find the other half of children? I mean, we think it's just because things are complex and we don't have the perfect test yet. But it means half the time we're like, okay, a week or two later or a month later, depending on the speed of the test, we can come back to you and say, okay, we understand what's causing your seizures. We understand what's causing your autism. And now we're realizing there's whole sets of conditions where we're like, oh, here's people we should be testing but haven't been. So, for example, cerebral palsy, about 10 to 20% of kids seem to have a genetic reason for the cerebral palsy. And so we should be testing kids with cerebral palsy more.
So let me make sure I'm understanding this. You would argue then that it gives us more diagnostic precision,
Correct.
as well as probably more clarity about prognosis.
Yes, families, I still get questions like, why should we do the genetic testing? Why should we do the genome testing? And there's three or four big answers. One answer is, of course, that it can tell us what disease we're fighting in a way that's granular enough to matter. We can sometimes find a treatment, sometimes not, but it's at least worth getting an answer so you have a chance of a treatment. The third is that for the family, knowing what is causing their child's condition is, I don't want to say it doesn't give them peace, but it gives them certainty that they're in the right territory of what they're doing. I think that is undervalued by us as professionals, but for the families, it makes a huge difference. And then finally, the pathway to the future for the family is uncertain without a diagnosis. And suddenly you're like, okay, here's a diagnosis. We know the pathway. We can't see the entire map of the future, but at least we know what route you're on and what some of the places you pass are going to be or what things you're going to have to deal with. So I think those are compelling reasons that the testing is worthwhile.
The analogy I've sometimes used in things similar to this is that we all sort of feel like our life starts as being totipotent and becomes pluripotent at some point. And at some point, our life takes a given course. And I think knowing what that course is, there is, I think, some, if not peace, some clarity that comes with that.
That's right. I think that some providers have felt that, oh, if you can make a diagnosis, but it's not a cure, is it important to do that? And I feel like that's almost a paternalistic decision that we as the providers are making because the families can choose how they want to use the information. Families and patients, they have agency and ability to make decisions about their lives. And so giving them the best information to make those choices is what I think we are supposed to be doing.
Would it be incorrect to say that you would envision a time too where genetic testing may actually obviate the need for some other testing? That what we've often done to this point has been to do cumulative testing of various types to make a diagnosis, but there may come a time, and this may not necessarily look at all the implications of a disease or disorder, but that the clarity can come very quickly, and then you can deal more functionally with what's going on.
I think that's a good point. I think already we're at the point for most of the testing that we do for genetic diagnosis should not be done other than the genome. We should not be doing urine organic acids or SNP arrays or a bunch of stuff. We should not be doing those tests. We should just be doing genome. That is very clear. But then even more, I think, for example, in pediatric neurology, we won't need to do MRIs as much because the MRI sometimes shows us the shape or existence of disease, but doesn't make the actual diagnosis, whereas the genome testing will skip to the diagnosis. And so I think that's going to change our practice patterns in pediatric neurology as well.
I know there's been some interest and research in looking at doing genome sequencing at some point in the future as a substitute for the sort of metabolic screening that we do in newborns. Do you envision that world?
That is a exciting question, Paul. I think we are testing those strategies for newborn screening using genome testing. There's lots of concerns on the one hand because there's issues with privacy and with genetic counseling that our friends in the government need to work on some. They need to get their act together a little bit about some of those issues, insurance coverage. But the reality is that we are now starting to miss conditions and treatments that we can offer people because we don't have genome level newborn testing. It's starting to become, as we have more and more treatments available, we're starting to do a little bit of disservice to people without having that technology. And so I think we're in a 10 to 20-year pathway to genome testing for newborn screening. I think it's happening. It's just whether we can do it well. That's going to be our challenge.
Yeah, fascinating. Let's talk a little bit in your world because that's where you do your research. So a mutation happens. What are the implications then in terms of nervous system development?
With a gene mutation, there's kind of two pathways I think about for what can happen for the child. One is that it may cause an immediate problem in how the brain forms or in causing the nerve cells to want to have seizures. And so that's something that we'll see clinically when the child is born or in the first, year or two of life if they're having developmental delay. So I think there's sometimes the gene problem has an immediate effect that we then see very early in life. The other type of gene change that we see is something where it creates a unstable system in the body where the disease is kind of waiting to manifest. And so an example of that would be a condition called ALD or adrenoleukodystrophy. The child or baby looks completely normal at birth, but in the first 5 to 10 years of life, that child could be at risk for brain demyelination and degeneration and death. And it's because the way the brain and the immune system are working is that it's kind of predisposed to have inflammation and it's just kind of waiting for a trigger. That's kind of the second kind of mutation that a gene can have.
So the implication being that, some things that may have an inexorable course based on the genetic variant and some that may be waiting for a trigger.
Waiting for a trigger or that have kind of a time dependent process because the system is unstable. And so no matter what it's going to happen. So for example, every winter, I know it's going to snow here. I don't know if it's going to be November 3rd or December 1st, but I know that I'm going to need to have my snow tire. Maybe this year's a bad
Maybe
example.
this year, maybe not
Yeah,
this year.
but
Yeah.
that I'll need to have snow tires and be ready. And so with some genetic mutations, you don't know when they're 3 years old or 7 years old, but you know it's going to happen. And so you want to be ready for that to be happening.
Looking at the philosophical and ethical side of this, is there a risk in looking for genetic diseases where you don't have a way to intervene? In classic genetics, the disorder we often talked about was Huntington's disease. You know, if you have Huntington's disease, you will have symptoms at some point. At what point in your life do you want to know that? How do you look at that?
So I think that's a great example as a way to kind of think through the problem of genetic testing and newborn screening. And so with the genetic testing, with the genome testing we offer in the hospital or in our clinics, or as people think about using newborn screening, we offer families the choice of how they want to stagger their results. And so the first level option is looking for genes or diseases that cause the symptoms. That's the why we're doing the testing. So yes, the family wants that result. The next level of testing results that the family can choose to opt in or opt out, as we say, is things that we're not testing on purpose, but things that have an immediate functional relevance for the family. So, for example, that is that you might be testing a baby because they're having seizures, but the baby might reveal that the family has a gene for breast cancer that then is very important that the mother knows about. And so that is a choice that the family can make to receive that information or not. And that is a decision that they are allowed to make. So I think that distinction is something that as we roll out more and more genome testing, we'll want to maintain that level of decision-making choices for the family.
So, in essence, information that exists somewhere in kind of a virtual lockbox.
That's right. And one of the, I don't mention this in the book, but one of the big programs we've been doing here at Primaries over the past 2 years now is a big genome testing program called Gene Kids. And Gene Kids is a genome testing program. It's for diagnosis. And so the family gets back the result. But then one of the things that's really been important to me about Gene Kids is that we store that genome information so that if the family moves to Oregon, or if in 20 years the kid has high blood pressure and needs to know what their gene variant is for high blood pressure, that information will be sitting there waiting for them to use. And I think that is a really important thing that as we use genome testing more, that we need to make sure those programs store and save the information are available to the families who did the testing.
There are a lot of important questions there that aren't there. I think that the hope we have would be that the number of diseases that don't have an intervention or that have an inexorable course, we hope those decrease over time.
Yeah, and the flip side of diagnosis is treatment, and that has also transitioned so quickly. Like this year, every pediatric neurology condition's like a rare condition, if you like, but there's a condition called Alexander disease, which is a very severe brain disorder. And for the past 20 years of my career, I've been making diagnosis, but been like, I'll see you once a year and kind of make sure you're getting services, but I can't do anything. Starting this fall, suddenly there's a treatment, and that's wow, okay, like we need to know who these kids are and we need to get them in the door. And so the speed of that treatment option is accelerating. It's exciting to see that, these options for families start to happen faster and faster.
An excellent preview for next week's episode. Josh, anything else do you think that the average provider ought to know about genetic testing for neurologic diseases? Or, I mean, since you're up to your ears in genetic testing generally, about genetic testing
I guess
in
two big messages about genetic testing. One is don't be afraid. It is not as scary as you think it is. And if you get genetic testing, like myself or whoever will be there to back you up for it. And then the second thing is that the answer is genome. If someone says, what genetic test you get, the answer is always genome. It's like a multiple choice test. Every answer should be genome. Like less than 0.1% chance of choices should it be something else. It's always genome.
You make an interesting point there. I was actually at a hospital-based discussion yesterday and talking about the difficulty of ordering things intelligently. And we need more feedback generally because you know that you want to know something and you go in and look for the right test. And as you, I think, make abundantly clear, some way to make sure that we're collaborating with people who will tell us the right test to get. Because I don't think anyone ever intends to get the wrong test. It's ever more complicated to get the right test. So the answer is genome.
And it's always genome, but you make a good point that it's almost like a separate episode about the electronic medical record system and trying to find the right test, right? That's like a whole set of problems.
Yeah. Josh, thanks so much. I feel smarter already. And so I really appreciate the time that you've spent with us. Thanks for your time making us smarter. Thanks for your time writing a book. For those of you, I remember the name of the book is
Dancing Eyes, Dancing Feet.
It's a good read. To our listeners, make sure and send your questions to questions@vcurb.com. We'll address those in a couple of weeks. Thanks for listening and tell your friends. Thanks, Josh.
Okay, thanks, Paul.
Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Thanks to Phil Wirkus, who composed the theme music. See you next time.